It was now with great pleasure at exactly 7 o'clock that I announce our last speaker of the day, who will deliver the Mortimer M. Bortin Lecture. The Bortin Lecture was established to honor Mort's passion for two aspects of the field of transplantation: graft versus tumor effects and collaborative clinical research. I know he'd be delighted to know that this year's winner is Daniel Weisdorf. Dan is professor of medicine and director of the University of Minnesota BMT program and associate chair for clinical research in the Department of Medicine. His own program has been at the forefront in exploring alternative donor transplantation, both with unrelated donors and cord blood, and in developing approaches to improve disease control and ameliorate transplant-related toxicity. He has distinguished himself not only by his leadership of his own program, but by the important roles, plural, he has played in the larger BMT community. He's had a key leadership role in advancing the research programs of the National Marrow Donor Program, of the International Bone Marrow Transplant Registry, and after these two programs combine, of the CIBMTR. He's currently Senior Research Advisor for the CIBMTR and Scientific Director for its Acute Leukemia Working Committee, one of our most productive groups, and we always hold him up as an example. He is a past chair of the Blood and Marrow Transplant Clinical Trials Network Steering Committee and, of course, past president of ASBMT. I consider myself really fortunate because I've gotten to work with Dan in many of these roles, and I have seen him in action. His success is due not only to his, incredible knowledge of the field and his expertise in clinical investigation, but by a rare ability to get people to work together and get things done. If you really want to get things done, you ask Dan. And if you really want someone to get other people to get things done, you ask Dan. I personally admire him for a whole lot of things: his knowledge, his vision, his equanimity under stress, which I try to emulate but never can. But really, the one thing I admire most about Dan is his devotion to the next generation, our successors. Dan's fostering of young investigators is actually legendary. In his own program, within the CIBMTR, and the BMT-CTN, he encourages junior faculty to lead studies and mid-level faculty to take leadership roles. But most importantly, he always makes sure that they get the kind of support they need to be successful. And there are many young and now not so young people who have been successful who owe a great deal to Dan for that. And I consider myself one of them, even though I'm not that much younger than him. He really did help me in the early years. This devotion to developing future investigators, of course, means that his legacy to our field will continue on for many, many years to come. It's really my pleasure to invite him to come and deliver the 2013 Bortin Lecture and to present to him a plaque honoring his contributions to our field.
Okay, whatever you want. So it's quite a pleasure to come. It's also nice that I was sitting up at the front and to turn around and see the room is no longer quite as empty as it was a few minutes ago, but which makes me quite gratified. But I'm going to talk tonight about AML over 60, which I've said talking about my generation, and I have no commercial conflicts of interest to declare. I do have a personal conflict of interest in that I've stumbled into at least half of that demographic, and I hope I'm still in remission. But I want to draw your attention to some old work presented a long time ago by Townsend and colleagues who had one perspective on aging. And for some of you who are a little younger, who are at different cultural backgrounds, this was auditory stimulation and aerobic activity collaborative group that first started working in the mid-1960s. But they were also very involved in the issues of dangerous circumstances and imminent mortality, and we're going to talk about acute myeloid leukemia today, something that falls into that category at least a bit. So here's the problem. Here's one piece of data presented by Rich Stone, a CLGB study presented about 12 years ago, showing that two different arms of a randomized trial of consolidation therapy for AML over 60 came out the same, but they both came out disappointingly poor. There was about 10% survival at 5 years. And a few years after that, Sharif Farag compiled data from a number of studies done by the CLGB and showed that the results were equally disappointing. Here's people in their 60s. If you're a little older, it's about the same. If you're a little older, it's even worse. And so we need improvement in the management of AML for patients in that demographic, and it's a lot of people. So AML occurs with a substantial frequency. You can see the number in the U.S. from SEER data is about 2.8 per 100,000. In between ALL, CML, and CLL, the median age at presentation is about 70. And the people under 60 have a low incidence, but you see it goes up tenfold above the age of 60 and about 20-fold above the age of 70. So when we look at the population, we're only looking at some of them. Well, the graph jumped out of the box. But we're only looking at the group over here. I can't move the box. And what we have to pay attention to, if we can put the graph over underneath the little brackets, is the people from 60 to 74 that we might be able to, if we think about how to make transplant work, we might be able to do something to improve their outcomes. So why is it harder in older people? Well, they have a little different phenotype of their acute leukemia, as we know. They have a higher incidence of high-risk cytogenetics presenting along with the disease. A larger fraction of them present following prior MDS. Because of the incidence of malignancies in middle-aged people, a substantial number of them, and a higher fraction than in younger people, have treatment-associated MDS or AML. When they get treated, they have lower rates of achieving CR, and it takes a longer time to get to CR, so they've had extended neutropenia and picking up the burden of infections that don't make them terrific transplant candidates. And of course, they have the comorbid illnesses that we're all trying to avoid by running really fast and taking an aspirin. The other problem is, of course, the older patients have older sibling donors, and so family donors are less often available for people in that age group, and alternative donors, which are pretty good but maybe not exactly the same, are where we have to turn for this age population. So this one is also going to have jumped out of the box, but the 5-year survival for people in the age group 65 to 74 from SEER data is quite a bit lower than in younger people. And if you put this over this one, we'll pay attention to that population and try and figure out if we can do anything. Well, 20 years ago, landmark paper gets published. HIDAC, intensified consolidation, changed the way we treat AML. We don't necessarily do it the same way anymore, but high-dose Ara-C, the really high dose at that point, yielded a 20% improvement in the outcome of patients in remission who got that intensity consolidation therapy, but that was only in patients less than 60. And when the same trial looked at the patients over the age of 60, you can see there was no improvement in the outcomes, and there was 20% or so at most of patients remaining in remission at a 3-year follow-up. So intensified consolidation, though making great improvements over this now 30-year period examined in these series of curves, with a 5-year survival going from the 15% up to the 65% for children, and even improving substantially in younger adults, there's really quite modest improvements in people in the 60-year and older age group, despite lots of studies and lots of imaginative work by many people in this room and, of course, elsewhere across the world. So why don't the patients do as well? Well, we have to figure out how to measure their biologic age and their fitness. So here's our previous author, 1965, and here's over age 65, currently age 67, I learned. still doing the same thing but with a little less leaping in the air, and that's probably true of many of us 40 years later. But if we take a look at what the fitness is across the population in patients this age, we might get a sense of how many might really be fit for intensified therapy. So, published this last year, Batul Aran led a study where we examined SEER plus Medicare claims data for patients over an 8-year time span across the whole U.S. who had the diagnosis of AML, and that identified 5,480 people who were in the Medicare age group, that is over age 65. And when you look at their already established diagnoses coded within the Medicare claims, you can figure out with reasonable precision some elements of the Charleston Comorbidity Index. And what you can see is that in patients 65 to 69, 70 to 74, nearly 60% of them had comorbidity indices of 0. That is, they didn't have any official diagnoses that count in a comorbidity index. 22% in both age groups had a single point on the comorbidity index score, and the rest of them had multiple points. Now, it isn't even that much worse when you look at the population with AML who are older, but if we just look at these people, we can see that about 60% of them, at least by their diagnosed comorbidities, are not excluded from consideration of more intensified and hopefully more effective therapy. So therapy did make a difference. Now, when you look at SEER and Medicare claims data, you can find out that they got intravenous treatment, but you can't find out what they got. And there's a little more elaboration in the manuscript that was published a couple of months ago. But of the 5,000 patients, you can see that 3,300 over age 65 got intravenous treatment, and treatment led to modest improvements in their survival from the time of diagnosis in all 4 age cohorts. Not much improvement in the people over 80, but not many of them got treated. And when we were able to examine whether there were any covariates that were available in this Medicare claims data that told us whether there were factors associated with improved survival, older age was a little worse. The comorbidity indices that I showed you on the last slide led to worse survival. Poorer income led to worse survival, and a pre-existing diagnosis of MDS led to poorer survival. So the things that we see in small series, you can find when you look at a population study. There were very few people in this Medicare claims data set who got charged for HLA typing, and there were very few who got charged for an allogeneic transplant. They didn't necessarily report to Medicare, but they did report, of course, to the CIBMTR, and we'll come to those patients a little bit later. So what about alternatives? A substantial number of baby boomers are fit, or at least they think they are, and they have the bad luck and they get AML. So what about alternative therapies that get provided to them? I picked out just a few to talk about. People are very interested in decitabine as induction therapy. Here's a study published by Kantarjian et al. Just this last year that show a little bit improvement in the median survival from 5 to 7.7 months when comparing decitabine induction to a treatment of the investigator's choice. But there's really not very good control of the survival, and there's 10% of the people alive at 2 years. Another drug with a lot of interest in elderly patients is clofarabine, and I picked out 2 series published about 2.5 years ago, one from Alan Burnett and another from Kantarjian. Here we look on the median age in these patients was 70, and they had pretty good response rates with clofarabine. There's 48% CRP and 30% or so complete remissions in the 2 series, with 30-day mortality of 10 to 18%. And 2-year survival of 20 to 30%. It certainly needs improvement. There's not a hint of any plateau on these curves, but it's something to think about because, of course, we do have to get the patients into some shape ready for more intensive therapy if that's the direction to go. So we have to ask whether we really should offer allotransplant, and we turn to my cousin Dave, who handles the conventional wisdom. And the conventional wisdom, of course, for years has said stay away from these patients. unless they're VIPs or there's something very special about them. And we learned starting in the 90s, as reduced intensity transplantation was developed by many of the people sitting in this room, that people can survive the treatment, but the problem is how to pick out who of those are sturdy enough to be able to take advantage of it. So we turned to some CIBMTR data a couple of years ago in an analysis, and I'm sure you've all seen, published, led by Brian McClune, looking at CIBMTR data of about 1,000 patients. These figures are with AML plus MDS. The later ones will divide the two. 10 years experience in allotransplantation in people over the age of 40, all getting reduced intensity transplantation. And surprisingly, or maybe not surprisingly, whether you were in the around 40 or you were over age 65, the treatment-related mortality over the first 3 years was the same. That doesn't mean to say that older patients are the same as younger patients. It says that our collective good judgment of figuring out who can survive an allotransplant is not so bad. Our end-of-the-bedside assessment of whether somebody is satisfactorily sturdy protoplasm to be able to get through the rigors of allotransplant says that we can pick out older patients who can do as well as younger patients. That's highly imperfect, and we all have different judgment about how that works. But what about the disease control? And of course, you don't have to look very hard to see on the right-hand panel that patients had the same relapse rate, whether they were 40 to 55 or all the way up to the patients who were over the age of 65. Now, of course, I said earlier that the patients with AML who are older have a higher incidence of having preceding MDS. So we examined whether AML with preceding diagnosis of MDS or de novo AML had the same outcomes. These are curves of leukemia survival in the 4 age cohorts, and you can see there's no difference in the 4 age cohorts in those with preceding MDS, and not much, certainly no statistically significant difference in those with de novo AML across the 4 age cohorts. Whether or not you think any of these results are good or you're proud of them, this is our collective experience in the 1995 to 2005 age group. Said at least we could pick out people over 60 or over 65 who were sturdy enough to have the same outcomes as people who were over 40. So there's a variety of series. By far, this is not an exhaustive list. I picked out a few published in the last 4 years where we're looking at allotransplant experience in older patients, and the majority of them in each of these series, which represent about 1,000 patients, had acute myeloid leukemia. They had both sibling and unrelated donor transplants. The median age was about 60 or older in all the series, and their disease-free survival ranges from 35 to 50%. Their overall survival about the same at 2 to 3 year follow-up. There are other series. We all have our PET conditioning regimens and our special GVHD prophylaxis, but most of the series are about the same. And it tells us that we can affect satisfactory transplants for people with AML in that age group, but we still have the problem of selection bias. How do we know which of these patients who were chosen for transplant would have done well anyway, and what's our denominator? Well, the first piece of a denominator was published from MD Anderson by Elie Esty when he was there in this valiant attempt to figure out in a prospective way. You take people over the age of 50 or 60 who have AML and figure out if you try and have them evaluated by the transplant team, find them a donor, and bring them to transplantation, can you improve their outcomes? And in this, I'm sure, very disappointing to the investigators at that point, only 14 patients went on to transplant out of the more than 100 who were about 100 who were evaluated, and the transplant recipients did pretty well, and those in all the other groups, whether they got a transplant evaluation or they didn't have a donor, all had disappointing outcomes. A hint with an internal, not perfect, but internal within institution in an experience center comparison, if you could bring people to transplant, they might do a little better than if you couldn't. Now, that takes some teamwork. It takes collaboration with a delicate dance, in some institutions more delicate than others, between the leukemia doctors and the transplant doctors to do something as simple as put the patient into the right kind of therapy. So we need the issues of comparison. And what are the comparisons that we can look to? Well, about 2 years ago, Sharif Farag led an analysis that was data from CLGB, examining patients between age 60 and 70 who were enrolled on cooperative group on the CLGB trials who achieved complete remission, compared to CIBMTR data for patients undergoing allotransplantation in first remission in the same age and in the same time interval, and we identified 94 and 96 patients in the two cohorts to be able to do a comparative analysis. And you see, we started this analysis at 4 months into complete remission to take care of some of the time to transplant bias and the very early relapses and failures that are never included in transplant series, but of course always included in chemotherapy series. So we start the analyses at complete remission plus 4 months in the two cohorts, both admittedly retrospective, and we see, not surprisingly in this age group, that the non-relapse mortality is higher, but not terrible. Not arguing it's great, but it's not terrible for this non-selected population for the transplant patients compared to the chemotherapy patients. And there was a dramatic reduction in the risks of relapse in those who underwent transplantation compared to those who underwent ongoing chemotherapy. And this isn't random chemotherapy out in the community. This is chemotherapy designed in prospective trials by the CLGB. So it was considered high-quality therapy at the time it was administered. And when we examine leukemia-free survival in the two groups, you see a significant advantage, a 15 to 20% advantage in leukemia-free survival for those who underwent transplantation, and a slightly less, 12% at 3-year survival advantage for those who underwent transplantation, presumably implying that some salvage therapies are effective, maybe even later transplantation for those who relapse in first remission after extended chemotherapy. And importantly, we could recognize that this improvement, advantage for transplantation over chemotherapy, was recognized in all of the cytogenetic subgroups. Again, not definitive data, but argues we need to do comparisons, but we need to reconsider this therapy. So not everybody has a sibling donor. When you get to be 65 or 70, your siblings might be sicker than you. They may have way too many comorbidities. So you have to look for some alternative donors. The marrow bone doggy chunks might be looking a little too far. But we can look at unrelated and cord blood transplantation for comparative data. So a comparison between data compiled on site with my own 2 hands in Paris last year, using data from the University of Minnesota, Hôpital Saint-Louis in Paris, and the Transplant Center in Nantes. We examined about 197 patients who were over the age of 50 who had AML in remission. 35 had unrelated donor transplants, 82 had match-related donor transplants, and 80 had cord blood transplants, and you can just guess where most of the cord blood transplants were done. It's not important. This is not a between-center comparison. It's complete between-donor comparison. And what you can see is that the outcomes, just short of 60% survival at 3 years, were the same with all 3 donor types. And when we looked at the patients from age 50 to 59, the three curves come together. When we look at the patients from 60 to 75, the 3 curves come together, arguing that if you don't have a sibling donor, a matched unrelated donor, or a satisfactory cord blood, at least by mostly Minnesota standards, could produce an acceptable, if not stellar, outcome. So we can look beyond the comparisons, though we still have to make some choices. And it's not always easy to have data from which to make the choices. So can we reproduce this in a prospective multi-center fashion? And I thank Steve Devine for these slides. So the CLGB got together with the BMT-CTN. Steve presented these data at the ASH meeting. And it was a phase 2 prospective study of allotransplantation for older patients with AML in first remission, using a reduced intensity preparation. A very conventional, widely used conditioning regimen was used. Flu-Bu, in this case with thymoglobulin, a peripheral stem cell transplant, followed by tacrolimus and short-course mini-methotrexate. And 123 patients underwent transplantation. About half and half, 58 and 65, got related and unrelated donor transplants. The eligibility was age 60 to 74, just the demographic we're talking about. More were male. The vast majority had intermediate risk cytogenetics, but a sizable number, about 20%, had adverse cytogenetics at diagnosis. And the donor age, you can see the related donors were the same age, not surprisingly, as the patients, and the unrelated donors were half the age. And I'm going to go through the details to emphasize that both options of donor type are the same. So here's acute graft-versus-host disease. Remember, this is a study with thymoglobulin given. The acute GVH grades 2 to 4 was only 9%, and it's the same in the related and unrelated donor groups. Chronic graft-versus-host disease, this is all chronic GVH, occurred in 26% of the cohort, and the same in the related and unrelated donor groups. Relapse and treatment-related mortality were 47% relapse, good or bad, we can all have a discussion about and argue. Treatment-related mortality at 2 years was low at 14%, and it was the same for both endpoints in related and unrelated donor transplants. And it led to 39% disease-free survival at 2 years, 46% overall survival at 2 years, again in a multi-center trial without the selection bias in an individual center, without the specialized habits in an individual center. These findings can be reproduced in a prospective study if people get together with a median follow-up of 3 years at the point these data were analyzed. We at least have this encouraging data to be able to examine in this age population. And importantly, the disease-free survival and survival outcomes were the same in the related and the unrelated donor transplants. So that's a few studies to look at, but what about real life? What have we all been doing over the last 10 years? And for that, I turned to the CIBMTR database to be able to examine what the population activity was. Well, here's 11 years of allotransplant experience for AML. And here's the age at which the patients were at the time of transplantation. And you can see that about 20% of patients are in that age group, over the age of 60. Turns out it's the same as everybody else except for the middle-aged population that we think is the middle-aged, except it's really that little group who's middle-aged or low middle-aged who have AML. The high end, where all the AML really exists, is still represented by only 20% of the population. And here's when we look at what's gone on from 2000 out to 2011, younger, a little older, 41 to 60, and the over 60 at the top in the, I guess, purple. You can see that for the last 3 years, several hundred transplants per year for AML have been done in the, these are U.S. transplants only, but from the CIBMTR database. What about what status the patients are at the time of transplant for AML? Half are in first remission. About a quarter are in second or later remission. And what I found actually quite surprising is that a quarter, or even in fact a little more than a quarter, have primary induction failure and are transplanted at the time of relapse. So some centers are really enthusiastic about transplantation in relapse, and others have stayed away from it. But it's a much larger number than I actually would have anticipated, even though we've analyzed it. And surprisingly, again, across the 4 age groups, the distribution of first remission at the bottom in blue, second or later remission in the orangish, and the patients with PIF or in relapse is about the same fraction in all 4 age groups. So we're not doing selections of either good or bad patients when we get to the older population who are proceeding with the transplantation. We're doing it the same way we do in younger patients, good or bad. What about the donor types? 40% have siblings, a little higher fraction have unrelated donors, 10% have cord blood. And again, when we look at the 4 age groups, there's a little less cord blood in the older population, but it's really not different once you hit 21. It's a very small fraction of people getting cord blood transplantation for AML in adults, obviously a larger fraction in children, and a roughly similar proportion of sibling and unrelated donor transplants across the various age groups. I find all of that sort of surprising, but that's what we're all doing, and somehow we've decided that we treat older patients, even though not too many of them, we treat them the same way, roughly, as we choose donors and the status at the time of transplant. And finally, across the CIBMTR, what do the survivals look like? Well, the bar on the left of each of these, the sort of grayish bar, is 2 years survival for all the patients altogether, so it's about 52, 53%. And across the 4 age groups for the first remission for the first remission patients, it falls off a little bit. It's the same for children and young adults, a little worse when you hit age 40, a little bit worse when you hit age 60, but it's still over 40% 2-year survival for this whole population of reports to the CIBMTR in first remission. And what I found actually even more surprising is, again, all the patients and the 4 age cohorts, second remission looks just like first remission. And that's probably, of course, because we might be choosing higher risk phenotypes for first remission, and that wasn't the point of this. This isn't adjusted for the phenotype of the leukemia. But here's the outcomes in the 4 age groups at 2-year survival in second or later remission. And in PIF and relapse, the outcomes are the same across all the age groups. So we're still selecting patients, but we're selecting them with roughly the same outcomes to be observed across all the age groups, in this case, starting from children. Well, prospective data is still limited. It's not completely lacking, but it's limited. And so there's a new trial working its way through many people's opinions about a proposal through the Alliance that we hope will be an intergroup study. The PI is Jalalettin Ustin, my colleague at the University of Minnesota. And our proposal is to examine patients with AML age 60 to 75 years old who are already enrolled on a U.S. cooperative group trial. And that provides, number one, a control group. It provides, number two, they're going to get modern, high-quality chemotherapy and supportive care. And we'll have a denominator from which to examine those who proceed to transplantation. And if patients consent, if we ever get this trial open, they'll co-enroll in this trial, which is to promptly initiate HLA typing and donor identification, whether in the family or an alternative donor. And the goal is to offer allotransplantation with reduced intensity conditioning by 20 weeks from enrollment on the trial, and people will proceed to transplantation if they have a donor, if they achieve complete remission, and they're fit, in the opinion of the transplant center. And we're going to test 2-year survival in 3 groups. Those who have a donor and proceed to transplantation, who are allocated to transplantation, although probably not everybody will get a transplant if a donor is found, even if they're called fit. And we'll compare them to those who have no donor identified. And we'll also compare those to the patients who, whether a donor is identified or not identified, were considered not fit for proceeding to allotransplant. They won't be part of the allocation between donor or no donor, but they're a very important group because they tell us how fussy we are in our selection bias, whether our selection bias is wise or not. And we'll compare the 2-year survival in all 3 of these cohorts. We'll also, of course, assess the feasibility of whether this can be done, how many transplants really take place for patients who achieve complete remission in this age group, what's their survival, what are the other relevant endpoints, what's their morbidity, and probably even more important in this age group, what's the outcomes in terms of their quality of life, and a formal assessment, if we can do it, of their functional recovery. Whether chronic GVH is a bigger burden in this age group or not, we don't really know. It's certainly probably not going to be a lesser burden. And we want to do some formal measures of what their functional recovery to really assess how healthy we can get the baby boomers back to playing golf or playing in the stock market or whatever they want to do. So wisdom comes from a lot of different places. And you can't just read 10 trials and know what the answer is. You have to think a little harder because the trials have selection bias. And for allogeneic transplantation for older patients with AML, I think we can continue to do it in larger numbers than we do already, but we have to do it with caution. We have to do it with our eyes open, and if we apply the right kind of discipline with controls to understand how well it really works, and understand the selection bias that allows us to bring patients to transplant, it can still be a success. Now, we still have to go back and look at the literature because it's not easy, but we can learn. And a younger colleague of Townsend et al., Tommy, who participated in many deaf, dumb, and double-blind trials, told us to see me, feel me, touch me, and heal me. And I think that's a lesson that if we figure out how to do it, we might be able to have some excitement at our feet or at the foot of the Wasatch Mountains. So I offer you all a happy Valentine's Day, and I want to say thank you to many people, but I'm not going to name anybody in particular. My colleagues and most importantly my friends at the University of Minnesota over a long period of time from whom we've shared experiences and we've learned how to work together and we teach each other things to make a real team. And I consider that to be the legacy of what we learned from Bob Good and John Kersey, who were the original leaders of our transplant program, and my current colleagues who are still active. And I also have to remember and thank all my friends and colleagues at the CIBMTR, from whom I've also had the chance to work with and learn and enjoy being partners with them over many, many years, and have the opportunity to meet friends from all across the world. And that's the legacy of collaborative study and collaborative interdisciplinary teaching that really is the legacy of Bortin, which makes me so proud to give this talk to you today. And thanks for all of your attention.